Let's talk about pharmacotherapy of hypertension. In this lecture we shall be discussing classification, mechanism of action, and clinical uses of antihypertensive agents. As you can see, we have four major classes in this group: diuretics, cardio-inhibitory drugs, vasodilators, and centrally acting sympatholytics. The diuretics include thiazide diuretics, loop diuretics, and potassium-sparing diuretics. Cardio-inhibitory drugs include beta blockers and calcium channel blockers. Vasodilators include Alpha-Adrenoceptor antagonists, we also call them alpha blockers. Then we have angiotensin converting enzyme inhibitors or ACE inhibitors, angiotensin 2 receptor blockers or ARBs. Then we have calcium channel blockers. So the calcium channel blockers are vasodilators as well as cardio-inhibitory drugs. In vasodilator group, then we have ganglionic blockers, Nitrodilators, potassium channel openers, and renin inhibitors. And finally, we will have a look at the centrally acting sympatholytics. So let's jump straight in. Let's start with diuretics. Now, diuretic drugs increase the urine output by the kidneys, which means they promote diuresis, and therefore they are commonly known as water pills. Now, you already know that if kidney excretes sodium, then water excretion will also increase. Now, most diuretics produce diuresis by inhibiting the reabsorption of sodium into the blood. Therefore, the sodium and the water remain in the nephron, and which is finally excreted out. Now, although there are 5 different classes of diuretic agents, including carbonic anhydrase inhibitors, osmotic diuretics, loop diuretics, thiazide diuretics, and potassium-sparing diuretics, but only 3 of them, including loop diuretics, thiazides, and potassium-sparing diuretics, are used in the treatment of hypertension. Now, thiazide diuretics include chlorothiazide, hydrochlorothiazide, benzthiazide, and chlorthalidone. Loop diuretics include furosemide, torsemide, bumetanide, and ethacrenic acid. Whereas potassium-sparing diuretics include amiloride, triamterene, and spironolactone. Now, spironolactone is slightly different than the other two because spironolactone is an aldosterone receptor antagonist, while these two agents act within the nephron. Carbonic anhydrase inhibitors are primarily used to reduce elevated intraocular pressure, whereas osmotic diuretics are used to reduce cerebral edema. Now let's have a look at the site of action of different diuretics in the nephron. Please pay attention to the different colors. Carbonic anhydrase inhibitors or CA inhibitors act on the proximal tubules. Osmotic diuretics partly act on the proximal tubules and also on the thin descending limb of loop of Henle and the thin ascending limb of the loop of Henle. Loop diuretics, as shown in the red, act on the thick ascending loop of Henle. Thiazides act on the distal convoluted tubules, whereas potassium-sparing diuretics act on the cortical collecting tubules. Now, loop diuretics are more potent than thiazides and potassium-sparing diuretics. They produce powerful diuresis and natriuresis. Natriuresis means excretion of sodium. The thiazides are the most commonly used diuretics. These drugs are less efficacious than loop diuretics, but are sufficiently effective to be used as antihypertensive agents. Potassium-sparing diuretics also cause excretion of sodium and water, but they are called potassium-sparing diuretics because they do not promote the loss or excretion of potassium, and thus they do not produce hypokalemia, whereas the loop diuretics and thiazide diuretics are associated with hypokalemia as a side effect. So as you can see here, these drugs will promote increased excretion of sodium and water, and therefore these drugs will reduce the blood pressure. Loop diuretics are also called drastic diuretics because they produce a very potent diuretic action. Now, loop diuretics are sometimes preferred over thiazide diuretics because the loop diuretics are more effective in unloading or excreting sodium and water. Diuretics are commonly used in essential hypertension. However, these drugs are particularly effective when coupled with reduced salt intake. The next class of antihypertensive agents is cardio-inhibitory drugs, which include beta blockers and calcium channel blockers. So beta blockers are also known as OLOLs, or this is an OLOL family, because these drugs end with a unique OLOL sound. They are further subdivided into three classes, including cardioselective or beta-1 selective blockers, the non-selective, which means blocking both beta-1 and beta-2, so the non-selective beta-1, beta-2 blockers, and the ones with an additional alpha blocking action. So the cardioselective or beta-1 selective drugs include acebutolol, atenolol, metoprolol, esmolol, bisoprolol, betaxolol, bivantolol, and nebuolol. Whereas non-selective drugs include pindolol, penbutalol, oxprenolol, nedolol, propranolol, sotalol, and timolol. And those drugs which possess additional alpha blocking action include libetalol, bucindolol, and carvedilol. The beta blockers are the drugs that bind to the beta-adrenoceptors and thus block the adrenaline and noradrenaline on the receptors present in the heart. The heart has both beta-1 and beta-2 receptors. However, the beta blockers predominantly bind to the beta-1 receptor and thus decrease the force of contraction, the heart rate, and the conduction velocity in the heart, thereby reducing the blood pressure. They additionally inhibit the renin secretion in the kidney, or in other words, we can say that they inhibit the renin-angiotensin aldosterone system and thus reduce the blood pressure by an additional pharmacological action. Calcium channel blockers, or CCBs. The calcium channel blockers, or CCBs, are also classified as cardio-inhibitory drugs. CCBs are divided into two different chemical classes, dihydropyridines and non-dihydropyridines. Dihydropyridines include amlodipine, clinidipine, felodipine, isradipine, nicardipine, nifedipine, nimodipine, and nitrandipine. Whereas non-dihydropyridines are further classified into two different chemical classes, phenylalkylamines, the drug is verapamil, and benzothiazepines, the drug is diltiazem. These two classes, dihydropyridines and non-dihydropyridines, differ not only in chemical structure but also in their relative selectivity towards cardiac versus vascular or arteriolar L-type calcium channels. The non-dihydropyridines, including verapamil and diltiazem, predominantly act on the heart and therefore are called cardioselective drugs. They mainly block the L-type calcium channels in cardiac smooth muscle, whereas dihydropyridines have more vascular selectivity, and therefore these drugs predominantly act on the vascular system rather than the heart, or they predominantly block the vascular or arteriolar L-type calcium channels. Now the L-type calcium channels present in the heart are mainly located in the cardiac smooth muscles as well as sinoatrial node and atrioventricular node. This is a cardiac smooth muscle cell and this is the L-type calcium channel. Now the main function of this calcium channel is to promote the influx of calcium into the cell, and you know the calcium is a contractile element and this will thus stimulate the cardiac smooth muscle contraction. Now these non-dihydropyridines, which are more cardioselective, will block these calcium channels or these L-type calcium channels and thus prevent the contraction of the myocardium. In other words, they will promote the cardiac relaxation. Thus there will be a decrease in force of contraction, the heart rate and the conduction velocity, and this way the blood pressure will be reduced. However, these drugs are commonly used in treating angina, which is the heart pain, by reducing the myocardial oxygen demand and reducing arrhythmias. And therefore we say that the calcium channel blockers reduce the workload on the cardiac muscle or the heart in conditions such as angina, when the cardiac muscle does not get enough oxygen due to any blockade in the vital blood vessels. On the other hand, since dihydropyridines have more vascular selectivity, therefore these drugs will produce relaxation of the vascular or the arteriolar smooth muscles and thus reducing the total peripheral resistance or systemic vascular resistance and the arterial blood pressure. And therefore dihydropyridines are mainly used in the management and treatment of hypertension. Vasodilators. There are a number of antihypertensive classes which cause vasodilation as their key pharmacological actions when used in the treatment of hypertension. They include renin inhibitors, alpha-adrenoceptor antagonists, which are called alpha blockers, angiotensin converting enzyme inhibitors or ACE inhibitors, angiotensin II receptor blockers or ARBs, calcium channel blockers, which have already been discussed, ganglionic blockers, Nitrodilators, and potassium channel openers. So let's discuss the first one, which is renin inhibitors. Now, although several renin inhibitors have been synthesized and are recognized by the suffix chirin, for example L-chirin, but L-chirin is the only compound in this class available for use since 2012. If you could remember from my previous lecture, we discussed the renin-angiotensin-aldosterone system in detail. Now this L-chirin is basically a direct renin inhibitor. It will directly inhibit the renin enzyme, and in this way the angiotensinogen coming from the lungs will not be converted into angiotensin I. Now, as you know, this angiotensin I is later on converted into a vasoactive substance, angiotensin II, which is a very potent vasoconstrictor agent, and it has a role in the elevation of the blood pressure. Now, one thing is very important to mention here, that since L-chirin possesses some serious kidney-related side effects, therefore this drug is not very popular. Now the next class is alpha-adrenoceptor antagonists, which are also called alpha blockers. Now these drugs are further subdivided into two classes: alpha-1 selective adrenoceptor antagonists and non-selective alpha-1 and alpha-2 adrenoceptor antagonists. Now the selective drugs include prazosin, terazosin, doxazosin, and trimazocin, whereas phentolamine and phenoxybenzamine are the non-selective alpha-1, alpha-2 adrenoceptor antagonists or adrenoceptor blockers. Now both alpha-1 and alpha-2 receptors are widely distributed in the blood vessel smooth muscles. These alpha-adrenoceptor antagonists, these all drugs, will block the alpha-adrenergic receptors on the vascular smooth muscles, and in this way they will prevent the binding of norepinephrine to these receptors. Now you know norepinephrine is a potent vasoconstrictor agent. Now once this receptor is blocked by alpha-adrenoceptor antagonist drug, there will be a vasodilation because norepinephrine is no longer able to bind to its receptor and produce vasoconstriction. Now these drugs dilate both arteries and the veins. However, they mainly dilate the arterial walls. Alpha-1 blockers are rarely used in essential hypertension, and they are not commonly prescribed for this purpose. However, the non-selective agents are usually reserved for the hypertensive emergencies caused by pheochromocytoma. Angiotensin converting enzyme or ACE inhibitors. These drugs include captopril, enalapril, fosinopril, lisinopril, perindopril, quinapril, ramipril, and trandolapril. Now these angiotensin converting enzyme inhibitors or ACE inhibitors will inhibit the ACE enzyme, which is responsible for the conversion of angiotensin 1 into angiotensin 2. Now this angiotensin 2 eventually binds to the AT1 receptors present in the blood vessels and causes vasoconstriction, which then leads to hypertension. Now once this ACE enzyme is inhibited by ACE inhibitor drug, the resulting vasoconstriction and the hypertension will be reversed. Now in addition to the vasodilator effects of the ACE inhibitors, these drugs also reduce the blood volume by their diuretic and natriuretic effect. Now diuretic means that they will promote the excretion of excessive quantities of water, along with a natriuretic effect, which is the increased excretion of sodium. And this is because these drugs inhibit the effects of angiotensin 2 in the kidneys, and in this way they will reduce the blood volume and hence the blood pressure. Our bodies contain a peptide known as bradykinin. Now it is known that ACE inhibitors increase the bradykinin levels by inhibiting its degradation into inactive metabolites, thereby increasing the levels of bradykinin, which is believed to be responsible for the troublesome side effect of ACE inhibitors, namely dry cough. And this dry cough is usually the cause of discontinuation of ACE inhibitors in most of the patients. Now the ACE inhibitors are considered as the first-line therapy in treatment of stage 1 hypertension. They may also be used in secondary hypertension caused by renal artery stenosis. I must mention that the angiotensin converting enzyme or ACE enzyme is also known as ACE. Therefore, these drugs will be called ACE inhibitors. Now let me share with you a very interesting thing here. The most feared coronavirus or COVID-19 also binds to the ACE receptors, and these ACE receptors are present within the human lungs. The virus then gets access to the interior of the human cells and causes the destruction. Now let's discuss about a related class of antihypertensive agents known as angiotensin 2 receptor antagonists or ARBs or ARBs. The drugs include azilsatin, candisatin, aprosatin, irbisatin, losartan, olmesartan, telmisartan, and valsartan. These drugs have similar effects to ACE inhibitors and are used for the same indications such as hypertension, heart failure, and myocardial infarction. However, their mechanism is different. ARBs are receptor antagonists, which means they block the angiotensin 2 type 1 receptor. We also call it AT1R or AT1 receptor on the blood vessels and the heart, and thus dilate the arteries and veins and thus reduce the blood pressure. They also promote the renal excretion of sodium and water, which is called diuresis and natriuresis, just like ACE inhibitors. Now, these drugs do not induce cough because that effect is associated with the inhibition of ACE. Ganglionic blockers. These drugs include mecamylamine, pantolinium, and trimethophan. Now, ganglion blockers are not used commonly because of their side effects and because more effective and safer antihypertensive drugs are available. However, they can be used for the hypertensive emergencies. These drugs are ganglion blockers as they block the impulse transmission at the sympathetic ganglia. Nitrodilators or nitrovasodilators. It consists of drugs, nitroprusside and nitroglycerin, which is also called glyceryl trinitrate. Now, nitric oxide or NO is a very important vasoactive substance which is mainly produced by the vascular endothelial cells. Now, this nitric oxide or NO is also present endogenously in the body. Now, these nitrodilator drugs basically mimic the effects of this endogenous NO. Now, these nitrodilators act directly on the blood vessels and release NO into the cell and produce vasodilation. However, if these drugs are used for a long time, tolerance may develop, which will decrease the drug efficacy. The problem can be solved by using a smaller effective dose or infrequent dosing. These drugs can dilate both arteries and veins. However, venous dilation predominates. These drugs are used to lower blood pressure in acute hypertensive emergencies usually. Potassium channel openers. They contain only one drug, minoxidil. Now, the potassium channel openers are the drugs which open the potassium channels in the vascular smooth muscles. Now, this potassium will move out under the influence of these drugs. Now, as you know, that inside of the cell is negative with respect to outside physiologically. Now, as the potassium moves out, it will cause the hyperpolarization of the cell membrane. Means the outside will become more positive with respect to inside. Now, as this happens, the calcium channels or the voltage gated calcium channels here will close down, and in this way the intracellular calcium will decrease. Now, with less calcium inside, the smooth muscles will relax or dilate. Thus, minoxidil will reduce the systemic vascular resistance and thus the blood pressure. These drugs are not the first-line agents in treating hypertension. This drug is, however, commonly used for treating baldness or alopecia when used topically on the scalp, especially in androgenic alopecia, and both men and women can use it for this purpose. And the last class of antihypertensive agents is the centrally acting sympatholytics. And these include clonidine, guanabans, guanfacine, and alpha-methyl dopa. Now, these drugs are not considered the first-line therapy for the hypertension because of their side effects. These drugs decrease the sympathetic flow by a mechanism which is largely unknown. Now, alpha-methyl dopa, which is commonly known as Aldomet, is considered the drug of choice for hypertension during pregnancy. Though it passes through the placenta, but is comparatively the safer option when compared with other antihypertensive drugs.